Kei te mihi nui atu ki a koutou katoa. I harikoa ana ahau I te kaupapa tēnei rā. He mahi tahi I te kaupapa. Ko Sarah Stevenson tōku ingoa. I tipu ora ahau I tauranga moana. Kei te mihi au ki Ngaitirangi me Ngaitirangi nui me Ngāti Pukenga. Kia ora. He karakia tēnei. Manawa mai te Māori nuku, manawa mai te Māori rangi, ko te Māori kai au. He Māori tipua, ka pakaru mai te pō, tau mai te Māori, haumi e hui e, taiki e. Tēnā koutou, tēnā tātou katoa. It's great to be here presenting to you all today. In case you did not understand my te reo Māori, our indigenous Māori language of Aotearoa, New Zealand, my name is Sarah Stevenson. I'm from Aotearoa, New Zealand. I was born and raised which the region is called the Bay of Plenty, or Te Toi, which is the highlighted blue part of the North Island there. I live with my two daughters, Eliza and Lola, and my husband Carl in the beautiful Mount Maunganui. And due to COVID, we've been exploring Aotearoa more than overseas lately. And this picture is taken of our travels down in the South Island to Waipounamu, and the picture is taken in front of Lake Pukaki, and it's such a beautiful country to travel around in, and so we are very lucky to be sort of locked down here. I have had the pleasure of working in 3 different countries in different health roles. So I've worked in Australia as a public health nutritionist for Queensland Health. And I worked in the UK as a health improvement specialist in Cambridge. And in my home country, New Zealand, I've worked in many roles, which has really helped add tools to my toolkit in the user experience space and then many other areas. So my passion in all my roles is to improve health and wellbeing through people-centered services and shifting the imbalances of the determinants of health to move towards equity. My current role is very expansive. In New Zealand, you must be a jack of all trades. We are small, but we are mighty. And so this means I have my head around a fair few health areas. I'm not going to touch on all of these areas today, but if time allows, I will share some insights on a few. So my area is in the population and women's health portfolio. Population typically means more upstream prevention. And overall, I design, improve, procure, and contract manage services across this range of areas. I work for the public health system, so publicly funded. On that note, I cannot assume that all of you folks from anywhere across the globe have in-depth knowledge of the New Zealand health system. So compared to many countries, we have a relatively good public funded healthcare system. In a nutshell, our public hospitals and specialist care is free to access. We have a community-based midwifery and early years nursing service that's also free to access. And we have general practices, which are private businesses, and they set their own fees for consultations and other health services. The New Zealand government does subsidise the fees of enrolled patients in a general practice, but the co-payment cost of a GP visit varies largely across the country. The government subsidises children under 13 to have 0 fees. And we also have an ACC system, which means that all relevant health care is subsidised if a person has had an injury as a result of an accident. We also have publicly funded dental care for children up until the age of 18. And there are more things that are funded, but I think that gives you an idea of the sort of gist of what our services offer. However, the New Zealand health service design, is traditionally clinically and financially driven. Some of our health services work well for some, but we have strong inequities in health outcomes in health service areas, especially for Māori, our indigenous or First Peoples. Status quo, health on the rooftop, that was an amazing experience. What I've found in my work is that it is possible to utilise human-centred design principles in the New Zealand public sector. It does, however, take more effort than status quo design and procurement of health services. And I'd like to walk you through an example of how user experience and health service design can pay off. So today I'll be focusing mainly on the program Improving Access to Long-Acting Contraception. Not knowing who I'm speaking to, I also can't assume that all of you know what a LARC is. So we like to call it fit and forget contraception. It includes implants such as the jadel, which is a rod that's implanted into your arm, and IUDs, which are normally implanted around the cervix. They last anywhere from 3 to 10 years, depending on the device and the clinical indicators. They're suitable for all ages, and most importantly, they're the most effective form of contraception. So what's the problem? Well, LARC uptake in New Zealand has been relatively low compared to other countries. There is a really strong inequity in service provision. So where you live, basically, and how much you can afford can determine your access and choices to contraception in New Zealand. What we've also found as a problem is that there's really minimal LARC training for healthcare professionals. In the real local context in the area that I'm from, the Bay of Plenty, Te Moana Toi, we remain to have one of the regions having the relatively high teenage birth rates. So 70% of births to teenagers in the Bay of Plenty were from Māori mothers, and the teenage termination rate was about 17%. It's quite difficult to actually get the baseline data for unplanned pregnancies because it's not something we tend to ask someone was this pregnancy planned? So really this is just an indicator of some of the unplanned pregnancies, but unplanned pregnancies can happen obviously all through fertility age bands. So the catalyst for the service development, well, funding does help, as we all know, and we're very appreciative that the Ministry of Health took some time to fund a program in each of the DHBs. They put $6 million across all the DHBs in New Zealand last year in order to try and improve the equity around contraception access in New Zealand. So our project objectives were specifically to increase the equity of access for low-income women and those living in areas of deprivation, to reduce poor and health and social outcomes for women and infants associated with an unplanned pregnancy and birth, and provide more women with support so that they can make a decision about their fertility and when to have children. The target population that we had for this funding were wahine, which is the Māori word for women, that live in quintile 5 areas or who are low income, which we have a community services card as an indicator of low income, or at high risk of unplanned pregnancies and poor health and social outcomes. So this included all young women, all Māori Pacific Island women, or wahine with substance abuse issues, and wahine in receipt of a state-funded benefit. So it was really important that those populations in particular were able to access our service well. So really broadly speaking, our service development methodology flowed from gathering insights from our target group of women and really drawing on the strengths of those insights around the service design model and the continuation of care. Insights from experts and service providers. We wanted to gain insight from literature and international models, who's doing what well in other places, and what interest can we gain from those models. And we needed to really understand who's doing what and where. So we performed a stock take of all our current workforce and services. So very briefly, we found from the literature that there had been really little change in contraception or condom use amongst sexually active students. So there hadn't been much change even since the introduction of these more modern forms of contraception. We found that cost is a significant barrier to improving access to contraception. However, the user experience is really important here because cost alone will not lead to a significant shift. So we knew that our services needed to be in a way that fit the user perfectly. We knew that effective contraceptive counselling or motivational interviewing is really essential. Counselling and low-cost access to LARC led to 75% of women choosing LARC. So we know that it was really important to have those effective conversations. And finally, medical professionals are gatekeepers to accessing these forms of contraceptions, because we found that even though our Royal College of Gynecologists recommended LARCs as a first line for contraception, we found that there was a really low reported knowledge of LARC skills, awareness, and knowledge. And so this was an area that the literature resonated with. So our project manager did some semi-structured interviews. So 70 experts and healthcare professionals, health managers and providers were interviewed. And really briefly, a summary from those insights were that no formal local training providers existed. There was no formal local training in our area. There was no national guidance on clinical competencies in the LARC area at the time. There was predominantly only a GP-led LARC service outside of family planning. So there wasn't any nurse-led services or midwife-led services. There were differences in service access in the West and the East. So across our region, there were really strong dissonance around where you could access what, limited access to training, and these opportunistic services were not being delivered at all. So the baseline service map, so we looked, the dark pink is the quintile 5, or the most deprived area, and the light pink were the higher quintiles, so the less deprived. And the dark blue circles represent that being a LARC in those spots, and the pink circle symbols had some eligibility funding. But what we also noticed in all of the areas was there was such a limited workforce, so there wasn't access to timely available services really anywhere. So there were many provider opportunities. So there were significant opportunities for nurses and midwives to perform the LARC services. It's within their scope of practice, and there was a really high interest from the providers. So we knew that if we had an opportunity or a platform to train and mentor nurses and midwives, they were really a great viable workforce to tackle into. We found that there was opportunity for existing LARC practitioners to be further enabled to deliver, as well as mentor and support other practitioners wanting to develop their skills and competency. We found that there was a strong requirement for clear guidelines to make sure that we had that consistency. Now, I think my most important part of the service design elements were the focus groups, gathering the insights from local women. So we wanted to provide a platform for low-income women to share their experience of accessing services. And we wanted to share their ideas on how services should be designed to be equitable, timely, convenient, and accessible. So we hosted 7 focus groups in quintile 5 locations for women aged 15 to 25 years. We had 46 women attend and participate. 72% were under 25 years, 52% lived in the Eastern Bay of Plenty, which is our more deprived quintile 5 area, more concentration of quintile 5 areas. 48% were from the Western Bay quintile 5 areas, and 76% of our participants were Māori. So how did we find their voices? We did a lot of social media campaigning and putting advertising on there. We worked with organisations that work with these young women. There were women finding women, and it was a snowball in that way as well. So we were really happy to hear these voices, and I just want to show hopefully a wee video clip of a couple of them.
Hello, my name is Sarah. I'm here today why should a woman who's paid for it, they're just trying to protect their body about it, but it's ignorant of it. Their body is.
So our skilled facilitators gained trust and empathy with women who shared their personal stories. We were committed to honouring the insights gained and keep the conversation flowing. We kept the initial questions really broad to try and gain insight around what does health and sexual health mean to each woman. And as you can see by this word cloud, there was a really broad range of words that came out through this. Mental health was mentioned, being confident and respecting our bodies. But we also found there was a really low knowledge on STIs and some confusion around the HPV vaccine, like does it cover STIs and things like that. People were aware of terms but not details. There was a really low indication of regular sexual health checks. And people said things like, oh, I heard that a Jadel stopped you getting pregnant as well as STDs, which is incorrect. So there was a lot of myths that were out there, which we hadn't assumed that there were some myths out there, but just how prolific some of these things were quite concerning. And we knew that that was something we needed to tackle in our service design as well. There were quite a lot of fears around contraception, like rods are scary. I heard someone with theirs moved to another part of your body. The jab makes you fat and gives you weak bones, those sorts of things. So there were a lot of fears from stories and a lot of misinformation. So it was something we wanted to look into. So we also found that around 25% of women accessing contraceptives do so through their general practice. But this incurs costs, debt, confidentiality. They were worried about that. They were worried about flexibility and convenience of perceived barriers. Family planning and sexual health clinics were indicated as preferred options, but these weren't actually really available in a lot of these places where they were. And on average, a woman was travelling at least 2 hours across the focus groups to get their contraception of choice. I'll share one story with you. One woman had 2 young children and she didn't want another child. Her preferred contraception was a Jadel implant, and she'd actually still had one in her arm at the time, and it was well overdue being replaced. So it wasn't actually effective at all for her at the time. But in order to get a new one, she needed to take a day off work. She needed to arrange childcare. She needed to drive 3 hours return and pay $300 to get her new. Afford that. She couldn't meet all those things in order to get that contraception that she actually really wanted. So she was in a real bind, and it was all caused by our current system. So I mentioned contraception knowledge. So no participants could recall contraception being discussed at school other than a condom demonstration, but they indicated that that was an essential place for learning about contraception. They basically talked about creating a space for a contraception conversation, and this was indicated as their preferred way of getting knowledge and awareness. So from these stories, we were able to develop some personas, and these personas have helped guide our service design. There's lots of different types of women, and there's different reasons for them wanting contraception. And we wanted to make sure that all of their ideations that formed these personas were listened to. So these were some of the concepts that we filtered through the service design. Overall, there was a low understanding that the most effective form of contraception was a LARC, and that a low understanding that LARCs were very suitable for most women. None of the women were either being offered a LARC or encouraged by their healthcare providers at the time to choose a LARC, and currently 15% had one. Following the presentation, the majority expressed their interest in considering knowing more. So we wanted to design a women's or a wahine-centered model. We wanted them to be in settings that were accessible and convenient to the target population. We wanted them to be client-centered, have that real strong counselling, consultation with like a motivational interviewing and options conversation, and give them accurate and unbiased information. We want them, all the services to be delivered at no cost or low cost to the woman where possible. So the service design principles, we sort of pulled it down to these key providers, and were mainly doctors in their general practice. Women wanted services closer to their home. They didn't want to have to travel 2 hours. It was just out of scope for many women. 30 minutes was the max. Women wanted access to a confidential, accurate, and unbiased contraception service. They had limited knowledge of contraception methods and limited understanding of their effectiveness. The choice of contraception is highly influenced by the contraception on offer, myths, and stories. So our model of care, we're looking at different settings and different providers rather than just providing contraception kind of hubs. It was clear that these needed to be spread out so that there were options for women. And this needed to be all underpinned by a really strong workforce development. So then we moved into service delivery, where we had provider hui or meetings face-to-face and via Zoom to connect with each other and share learnings, developing the policies and standards underpinning the workforce development and the training packages, building a social marketing strategy to try and improve that and reduce those myths out there and also drive demand for the service, and ensuring that wahine were participating along all levels of the service development. So I'll talk a little bit about the workforce development. We developed a training program that was free to service providers, and because even our nurses and midwives, you know, having to pay for the workforce development was a barrier for them to become trained. We wanted to deliver the training as close to their home as possible as well. So the local service included expert trainers, and they would travel out to these remote communities and train midwives and nurses who were out there in the community. And we developed Bay of Plenty guidelines. So just, you know, quickly, the competency and training matrix. We also thought it was the women who were involved in the focus group wanted to keep on being involved, and they discussed being there a peer educator. We thought that was a great idea. So we've established a peer educator program where we focus on social influence and motivating women in their communities to have contraceptive conversations and provide access to unbiased information and myth busting. So these have been really popular. So we had our service launch at the end of last year and introducing Protected and Proud. So Protected and Proud is about creating a space for women in wahine to kōrero and enhance understanding about the most effective contraception to help support informed decision making. By enhancing self-determination, Protected and Proud ensures that contraception services are available in the most convenient settings as indicated by women, what they want and how they want to use the services. We were gifted the subtitle Me Arokoe Ki Te Ha o Hini Ahuane, and this is really a tribute to Hini Ahuane, who is the female created by Tani Mahuta and his siblings, and she is a living being in her in terms of fertility from a Māori perspective. Hini Ahuane is a wellness for Māori wahine, so it was really quite a nice link to the service, and we were really grateful to be given that name. And the branding was, and the name was selected by women through an Instagram poll, and they voted for this name, and the design as well was determined by them. So our website has been live since February, and there've been it was in the end of June, there was about 600 visits. There's been a lot more now. With each visit averaging around 2.5 minutes, and have that conversation in the online space and give that unbiased information. Workforce development, we 49 new practitioners and counting. We've had a 320% increase in nurses delivering the LARC service and 11% increase in midwives and counting. We're seeing really strong uptake in nurses and midwives wanting to become LARC practitioners, and yeah, it's been a really fantastic thing to offer to our workforce as well. So we're seeing a real increased knowledge with healthcare professionals for LARC as a first line option. And it was interesting that throughout the training, we did hear that professionals had a really low understanding that LARC was actually suitable for young women and postpartum and various other elements as well. So the myths weren't just in the community, they were also in the workforce. So this increased confidence has been absolutely impacting on the volumes that we've been seeing. I mentioned the social media presence, so these are some of the just a screenshot from our Instagram page, and so we have a regular Instagram and Facebook and other social media, which we're hoping will increase that self-determination for women to choose the most appropriate contraception. I would hope at this stage there'd be some form of increase in that so far. I mentioned our volunteer peer educator program. So our first workshop took place in February 2020. We had a real diverse group of women who shared their lived experiences, their perspectives, and have found a safe and supportive place to learn and gain knowledge from each other. And we did have a bit of a setback with COVID in this service, because our subsequent peer educator program sessions had to be cancelled, but we've picked up some more again recently as New Zealand has moved back into level 1. So yeah, the service had taken a wee bit of a hiatus and then came back on again as New Zealand has been able to curb COVID again. Yeah, I mentioned our service mix. We're going for a non-traditional service mix. So providers are anywhere and everywhere now. The service is being provided by midwives and nurses in people's homes. So as convenient as that, especially in the rural area, we've got a rural midwife who delivers LARC services in people's homes. All the way through to their normal well child or plunket, or their early years nurse visits. The nurse will offer that form of contraception as part of their service now in some areas. We have iwi hauora or Māori hauora health and social services, having nurses trained there, just nurses being able to deliver the service for free to eligible women. So the protected and proud services are free for targeted women to access. They're closer to home, so they're less than 30 minutes from pretty much everywhere in the Bay of Plenty now, so much more readily available and available in a range of places. Nurse or midwife delivered as what the women were asking for. We're tackling the myths, and really, really early, like I said, COVID did impact our service delivery, but you can see the months before we started service establishment versus after we had been running our service, you can see that we've seen quite a strong increase in our inserts, and that's just been going up and up ever since. So we're hoping that we get this message out there, and yeah, and we keep going. Theo, do we have any time for more examples, or would you like me to pause?
So because we two of us speaks this out there, Sarah, it'd be great if you can just continue, let's say for about 10 minutes, and what we'll do is we'll take a break till about midday, and then we'll start the panel discussion at about 11:50. So you've got about 10 minutes on the floor, and then we'll do a question session.
Okay, great. So I'll just quickly share one of the examples from our first 1000 Days program, which is a program that we're looking at the unbroken chain of care from pregnancy through to 2 years on, 2 years of life. And that's a really important time of life where children need nurturing, very much wrap around, as the slide shows, around the whole of the community. And yeah, how there's a growing evidence base around how important the period of conception through to 2 years of age is, and the experiences and exposures that happen during this time are critical to shaping the future of the individual. So we know that the brain is rapid, and so we know that the absence of basic things throughout the pregnancy and the early years, like good food, breastfeeding, loving relationships, alcohol, smoking, and even holding eye contact, can determine what the lifelong outcomes of a child. So this particular project I'm going to talk about is improving Māori breastfeeding rates. So there's lots of reasons to breastfeed. It's one of the core public health, as I'm sure many of you would know, initiatives. So, however, the problem in the Bay of Plenty is that we see quite a significant drop-off from initiation of breastfeeding for Māori compared to non-Māori, and we haven't seen any overall population level improvements for a very long time. So there's a really strong difference in service provision across the Bay of Plenty again, and different levels of support and access. And these are back from a couple of years ago before this service was developed. So the Midland Breastfeeding Framework ushered a broad range of insight gathering workshops and stakeholder interviews, expert interviews, and so we were able to gain some very strong insight into what was needed to improve rates or give it a go. So the lack of community-based lactation support was really strong, but what the woman really talked about was the need for that social support. You know, it's all good to have access for when the wheels are falling off and breastfeeding's not going well, but actually they're exhausted, they're sleep deprived, and sometimes it's that that sort of support that's needed on that level. So so these were some of the this was the advertisement for the focus groups for this one, and some of the quotes of these were all teenage participants. These were all teenage mums. And, you know, they say things, I just ask Uncle Google things. I don't want to ask my family. Some of their experience, I didn't chuck her on her breast at all because I was scared of all the stories. Teen mums are also really aware of the double standards that exist in people's attitudes to breastfeeding in public. So their perception is that it's okay to show off your breasts in a sexual way, but it's not okay to breastfeed in public. And so teen mums do think it's okay to breastfeed in front of their family, though. So, yeah, there was some strong dissonance there, and also there was a real lack of where to get information from and how they receive information. They didn't want paper-based information. They don't want a pamphlet. And yeah, so I think that's pretty common in most services, but that seems to be the way we typically give people information. So I went through a procurement process and used the consumer insights to build the service procurement. So went out to market to try and find a service provider that would provide a two-tier breastfeeding support. The lower tier being that I mentioned, that breastfeeding peer drop-in clinics, home visiting, a range of different ways of getting support, phone, text, social media, public awareness type element, and workforce development, again, being an issue in this area. So one thing I did in the procurement, which is something I do in all my procurements, is always have a consumer with equal voting rights on the panel, on the evaluation panel. So a breastfeeding mum, we had 6 panel members, so the head of midwifery and all sorts of really, you know, important people, but the consumer has the equal voting right as all those people. And I found that really important. They asked the most interesting questions. So in the focus groups, this is me sitting down chatting to some teen mums. We also picked up on a broad range. I should mention the breastfeeding service now has been in play for nearly a year and a half now, and we've been seeing some amazing uptake of the service and an improvement in local breastfeeding rates since it's been there. So I mentioned these focus groups. I go broad, so we don't always have to just talk to the people in front of us about the topic, because they want to talk about lots of things. So one thing that came up was access to ultrasound scanning during pregnancy. In the Eastern Bay of Plenty, there's one ultrasound provider, which is a private business, and they charge a co-payment each time the woman comes in to have her scan. And these teens talked about it was really hard to find money to pay the scan. And one young mum actually said, my mum, because she's living at home with her mum, she's 15, and she said my mum had to choose between feeding us that week for that $40 or paying for my scan. It was such a difficult thing. So that really triggered a change in the way we fund scans to reduce that inequity. So in the Eastern Bay, we now fund that co-payment. Did midwife focus groups, and there were lots of insights, but something about gaining empathy. They just said it was really good to be heard. And there's something about listening to your workforce. And as a public health system, it's not something we're always really great at. So I just wanted to share that little example as well. And finally, one last example that probably seems quite different, but as I mentioned at the beginning, my portfolio is really broad. We looked at trialing vaping initiative at our mental health unit called Stevenson. So this is an inpatient unit. I should note that in New Zealand we do have regulation around vaping in our our government has passed that act. So we had an innovative partnership with our mental health service for smokers when they present at the mental health unit. So we have a smoke-free policy as a DHB. So usually when they turn up in their crisis, their smokes are taken off them. Everything's taken off them. So it's a really unpleasant time for them. So people who access the service are in a crisis and they're high risk to themselves or others. Really high rates of smokers. They're scared, they're aggressive, and they have impaired judgment at that time. So our project was we wondered if by offering them a vaping device rather than traditional NRT, which had really low uptake, and we've tried lots of different things around nicotine replacement therapy, and we've literally had no success with those initiatives. So we wanted to test if providing the vape was a better option for clients, because we had heard from them that was something they wanted to try. So we adopted an improvement methodology. It was really grassroots done, and our aim was to see if we could reduce the length of stay, lessen aggression, or improve safety of staff who patients are quite aggressive towards, and promote stop smoking as well. So them, and a really interesting thing with them, there's an auditor that interviews them quite frequently, and but normally they decline. She says, no, nobody wants to talk to me about anything. But when she said, hey, can we talk about vaping? They said, yes, I'd love to talk about it, which just showed there was a huge difference how they wanted to share their story. So at the time of the interview, the people had used the vaping device for either 5 or 10 days, up to 5 to 10. 7 out of 10 of the participants were Māori, and 8 out of 10 of them were male, which really represented the type of users of that service. We found, you can see the graph as a nutshell, that people reported reduced stress, reduced agitation, aggression. They had a better relationship with staff, and they had already seen the physical benefits of switching to a vape. And some of them said, yeah, I'd actually keep vaping rather than smoking when I get out. We also interviewed staff, and we looked at incident reports, and incidents on aggression against staff reduced during this period. We didn't think it would be this successful. We were really surprised. But some of the direct quotes, as this is user experience, people said, "What a bloody brilliant idea. I'll be using it when I get home for sure. If it wasn't for the vape, I would have been clawing at the walls." So really strong sentiments from our service users. So that's it. I hope I just scraped under the 10-minute extra there. Does anybody have any questions?
Perfect. Thank you so much for that, Sarah. It's really, really insightful. And just by the tone of voice, it sounds like you were very sort of vested in this and very excited about the research. Is that correct?
Yes, I'm always excited about hearing from our people and trying to improve their health outcomes. That's this frame of mind I come from.
Perfect. So I just have one question here from my side, is just how are you handling research at this moment, or sort of any data during the sort of pandemic period when you, I'm assuming that before you were doing in-field research, so now it's all remote.
Yeah, so we've had to pause some of the newer initiatives. So for example, we were looking at like a STI quick test project as well, and we sort of had to pause that during the COVID times. And like I mentioned, the peer support groups, they all had to be paused. So gathering those insights, and yeah, we essentially have extended our time frame in the hope that we'll be able to get out there and do some more of that field research and follow up.
Okay, excellent. Thank you. And just how big is your team?
So I yeah, it sounds like I've got lots of people, but I don't. So I tend to partner with different services that I'm working with, and also I get consultants to help me. So at any time it could be just me and one other person, or it could be a collection of other people. But in New Zealand we do, like I said, we're jack of all trades. We get in there and we boots and all.
Okay, fantastic. Look, I'd love to engage with you a little bit more on that, because I think it's quite a useful use case, especially coming from a third world country as ours, because I'm based in South Africa, where I think it would be super useful with regards to your case studies and just what you could offer to our sort of NHR year.
Love to help. It's amazing to be part of this global community. I learn a lot from other countries and get insights from them, and then run it through the lens and develop and co-develop with our communities. Yeah, so I'm happy to share and connect.
Okay, great stuff. Thank you so much for that. Yeah, so that concludes our session. Sarah, thank you so much, and I do appreciate your time.